Professor Wall. So.
Kia ora koutou. Thank you very much, Brett, for your very lovely introduction. And welcome everybody to this exciting session that I'm very privileged today to be able to facilitate with our expert medical advisory panel, providing you with some kind of 7-minute shortish presentations in their areas of expertise, followed by a Q&A discussion, which will be also joined by some more experts and panel experts who I'll introduce to you later on. So rather than having Q&As after each of the presenters, I know that you're really familiar now with the chat function in Zoom. So as the speakers are speaking or after their talk, please just put in your questions that you have for them in the chat function, and we'll either address that concurrently or at the end in the Q&A session with the other panelists. So I'm really looking forward to this session. So the first presenter that we have today is Dr. Kristen Kenrick. And Kristen is a senior lecturer in the Department of General Practice and Rural Health at the Dunedin School of Medicine at Otago University. And before becoming a full-time academic, she worked as a GP for many years, so has got first-hand experience of supporting patients with celiac disease and their whānau. In 2019, Kristen completed a PhD investigating the diagnosis of management of celiac disease in New Zealand. And she is going to talk to us today about, so you have celiac disease, things you might not know about it. Over to you, Kristen.
Thanks very much, Claire. And just one other, I suppose, qualifying trait that I have for this discussion is I also have celiac disease and have had for a number of years. So, so I speak from some personal experience as someone with celiac disease, as well as having some medical expertise relating to it. So I'm just going to share my screen and then I'll just whip through my slides. 7 minutes doesn't seem like a very long time, so hopefully I will be able to get through that in a timely fashion. So, so just some quick points really to sort of sharpen up your knowledge, I suppose, for those of you who have celiac disease or who have family members who might have celiac disease. So the first thing is that it's an autoimmune condition. And so that means that what happens is the immune system kicks into action when gluten is consumed, and that then sets off a process that causes damage to the lining of the small intestine. So someone raised a question, had a question in the chat during the session that Tom did, asking, is celiac disease the same as gluten intolerance? The answer to that question is no, it is not the same as gluten intolerance. Gluten intolerance is not an immune or autoimmune process, and so it doesn't cause the same inflammatory reaction or lead to damage in the gut. So there is a distinction between how people with celiac disease and people with gluten intolerance should manage those conditions. Because celiac disease is an immune reaction, it causes lots of other symptoms, many of you will be well aware of. And the other thing to note is that once a person's on a gluten-free diet, the reaction to inadvertently consuming gluten will start to happen within sort of 2 to 3 hours, and often is actually characterized by nausea and or vomiting. So, so gluten exposure, once you're gluten-free, tends to set off those kinds of symptoms. The second thing I wanted to sort of point out is what to do about celiac disease within the family situation. So we know that first degree relatives of people with celiac disease have an increased risk of also having celiac disease. And in some studies that risk may be as high as 20%, other studies have it a bit lower. First degree relatives are parents, children and siblings of the person who has celiac disease. So we do recommend that people who have been newly diagnosed should advise their first degree relatives to be tested. One of the questions that then comes up with that is, how often should my family member be tested if their first test is negative? There's no sort of clear or simple answer to that. The guidelines haven't been sort of formalized around that, but the common sense approach is to retest if symptoms or conditions that could be associated with celiac disease emerge, and to have a fairly low threshold for doing that. But there's probably not much to be gained by having an annual test for celiac disease if nothing has changed in a person's overall health status. Another option to consider in that situation is to offer family members a gene test. And just to briefly touch on the gene test, the things which GPs are familiar with, you have to get the the gene test requested through a GP. You can't just turn up to a lab and ask to have it done. The things to remember about the gene test, and most GPs are aware of this, is that a negative gene test is very helpful. If your family member does not have the gene, then they will not get celiac disease. If your family member does have the gene, it doesn't necessarily mean that they will get celiac disease, but it does mean that they've got the potential to develop celiac disease. So for some people who don't want to sort of be worrying about having celiac disease over their lifetime, for some people it's very reassuring to have a negative gene test, because it means that they won't get celiac disease, basically. Bones, we hear a lot about bones and celiac disease, and at least 50% of people will have reduced bone mineral density when they're diagnosed with celiac disease. So that means that their bones aren't quite as strong as they should be. And that doesn't mean they've got osteoporosis. Osteoporosis is at one end of the spectrum of reduced bone mineral density. It's when it gets to a point where it's starting to potentially interfere with health. It's likely that that's caused by persistently low levels of vitamin D and calcium, particularly in undiagnosed disease, and inflammation that goes with celiac disease probably impacts on that as well. Where it becomes problematic is for people who, well, potentially problematic is for people who have been diagnosed as adults. So people who've had celiac disease diagnosed as an adult should have a conversation with their GP about whether or not they should be investigated for osteoporosis or reduced bone mineral density. But going on to a gluten-free diet does lead to improvements in this, particularly for children. Their bone mineral density will recover, and for adults there'll be some improvement in it. Celiac disease and infections. There is a link between celiac disease and how the spleen functions. So the spleen is an organ that we all have that's involved in fighting infections, particularly bacterial infections, and it's also involved in regulating the immune response. And it can be affected by celiac disease. It's not very clear how many people this does affect, but I would say if you have celiac disease and you are a person who is prone to infections such as pneumonia, ear infections, sinusitis, which can all be caused by a particular group of bacteria that the spleen might be involved in helping fight off, it might be worth asking a GP about having a blood test to check whether the spleen is working properly. If it's not, then you might be a person who benefits from vaccination, particularly against a bug called strep pneumoniae. Children are routinely vaccinated against strep pneumoniae and a couple of the other organisms that also contribute to these infections. So children with celiac disease are not people we need to worry about with regards to this at the moment. Celiac disease and other diseases. People with celiac disease are at increased risk of developing other autoimmune conditions, particularly thyroid disease, occasionally type 1 diabetes, and a range of other conditions. And the message is that you should be tested for those conditions if symptoms develop. The one to watch out for here is thyroid disease, because the symptoms of thyroid disease, particularly when the thyroid is not functioning as it should, it is underperforming, the symptoms are very subtle. So it's worth sort of raising that as a possibility with health professionals, and certainly it is flagged to health professionals that monitoring a person's thyroid function is something that they should be aware of when a person has celiac disease. And my final slide is that in the meantime, the gluten-free diet is the answer, at least for now. And sticking to a gluten-free diet, it should lead to an overall improvement in your health, and in all but rare situations actually, but it may take some time. So it's something to be patient with and keep trying. Don't give up, because it is the thing that will improve your health overall. Your blood tests should return to normal or close to it in the 12 months following diagnosis, but there is quite a lot of evidence emerging now that it does take quite a bit longer for the gut to recover. But but the take-home message from this is if you've got symptoms that are not improving and or the blood tests that you've had are not trending towards normal, then the first place to look is at your diet. And so see a dietitian for help with that, and then also talk about it with your healthcare professional. The end.
Thank you very much, Kristen. That was great summary of things that, yeah, often, well, I've learned some new things there, things that I didn't know about, and I see it's created quite a lot of interest too in the chat, which is fantastic. So we can get to discuss those questions later on. And thank you very much for sticking to time. It's quite a hard thing to do, isn't it? 7 minutes. Thank you. So moving on to our next speaker. Our next speaker is Professor Andrew Day. Professor Andrew Day is an academic paediatric gastroenterologist based in Christchurch, and he has a long-standing clinical and research interest in celiac disease. And he is also currently our chair of the medical advisory panel. Andrew is going to talk about 2 gluten-free diets and beyond, life after diagnosis of celiac disease. Thank you, Andrew.
Thank you, Claire. Good morning, everybody. So with Buzz Lightyear, we're just going to have a little tour of what might happen after diagnosis of celiac disease, not just the gluten-free diet. And Kristen's touched on some of these things already. So we could simplify this in terms of saying there's some ABCs that might happen after and continue to happen after a diagnosis of celiac disease. So what might these be? So I'm just going to go through these briefly, but some of these, there's 2 or 3 in the yellow that I've highlighted that I'll touch on in a little bit more detail. So let's go for the A's first of all. So adherence, sticking to a gluten-free diet. Anthropometry, do people recover in terms of the weight that they've lost? In children, we worry about them getting taller. But general nutrition overall in terms of weight and height is important. We've already heard a little bit already about other autoimmune conditions, so screening for these is important. Appointments, who's going to follow the person with celiac disease, how often are they going to be seen, and all those sort of things are really important. B's, so bones, we've just heard a little bit about already, and that's really important. Biopsy, does someone need a repeat biopsy and why? Blood testing, so following up in terms of the antibody tests, but also documenting micronutrients, vitamin D and iron. Are they low and have they corrected with appropriate intervention? And then the brain, thinking in terms of quality of life and the psychological impacts of celiac disease, and anxiety and depression and other things that might go along with that. C, has the person's symptoms got better, their complaints, has their tummy pain got better, and so on. Clinicians, who's going to be looking after the person with celiac disease? Is it the GP? Is it the gastroenterologist? And the really critical role of Celiac New Zealand playing in terms of the overall management, not just in the days after diagnosis, but the ongoing aspects beyond that, in terms of support, resources, information, and updates. D, for diet. Diet, and once again, diet. Gluten-free diet being critical, as Kristen said, in terms of the treatment that we have at this point in time. So let's touch on 3 of these things in further detail. So in terms of anthropometry, regaining any lost weight, resuming normal growth patterns. And in children, we worry about, are they getting taller appropriately? Maintaining an appropriate body mass after commencement of a gluten-free diet is important and has been illustrated as an issue both in children and in adults. The study a few years ago showed in children after commencement of a gluten-free diet, the percentage that were obese doubled. And this is an issue in adults as well, and this is just two glimpses of this. So first of all, one group showed that adults had a lower BMI at diagnosis, and that 16% moved from a normal or low BMI to an overweight body mass index. In another study, which is perhaps a bit more reassuring, 90% of these individuals were normal or overweight at diagnosis, 10% were underweight. Almost all of them had weight gain after diagnosis. But in this group, which was based in Southern Europe, the Mediterranean diet was perhaps protective against them becoming overweight or obese after commencing a gluten-free diet, which is an interesting new perspective on that. Adherence, sticking to a strict gluten-free diet, avoiding obvious contamination and avoiding the potential for inadvertent exposure. And there's been lots of discussion this morning in terms of going out to eat, and I think Wellington was raised by some comments as an issue in terms of finding somewhere to go out to eat, and obviously that's one aspect of inadvertent exposure. Adherence can be assessed in lots of different ways. This is a study a month or so ago, just looking at dietetic questions and reported symptoms, showing a huge variation in terms of the rates of adherence across a number of different studies. How one is diagnosed might be important as well. So this is a study from Italy where they assessed, were these people 20 years after diagnosis having an optimal gluten-free diet? Those that were asymptomatic, detected just by screening a population, only about half of them were adherent. 80% of those that had symptoms at the time of diagnosis were maintaining an optimal gluten-free diet. And obviously in terms of gut recovery, but the systemic aspects of celiac disease, it's important to be maintaining adherence, not just for the first month, but for ongoing decades. How about diet? So clearly, as Kristen's mentioned already, a strict lifetime gluten-free diet is the treatment that we have. And this is easy to say, but may sometimes be not so easy to do. Meeting with a dietitian and having contact with a dietitian is really important, but self-education and access to resources that include reading labels and understanding things is also critical, in addition to hearing from a dietitian or meeting with a dietitian. And asking this question, is this actually gluten-free? And diet, not just in terms of taking out gluten, but managing diet overall is important. And there's a number of reports illustrating this. In this report, many individuals had above recommended amount of sucrose and saturated fatty acids, but insufficient fiber, vitamin D, magnesium, and selenium. And furthermore, in another study, fiber, iron, and calcium intake was assessed, and less than half of the ladies in this report had their recommended intake, but a variable amount of the males included had recommended intake. So it's not just taking out gluten, it's what the rest of the diet involves is obviously important as well. So what is the best way for follow-up after diagnosis? How would this impact upon the outcomes, and how can we do better? Are questions that are being asked, not just in New Zealand, but internationally. And I was interested to see this report, which just came out a month or so ago. This is the MOVE-C study, where they had an intervention of high-intensity interval training, which sounds exhausting, plus lifestyle educational intervention, and they compared this to no intervention. And those that had the intervention had improved quality of life and exercise behaviour, and decreased gut symptoms, improved self-compassion, and importantly, adherence to a gluten-free diet, following and maintained for 3 months. So management is an ongoing thing. Gluten-free diet is one key part, but all these ABCs are also important to emphasise, and to emphasise that the people are caring for you. And I'll leave you with this illustration of a gluten-free haircut. Our imagination goes wild. Thank you very much.
Thank you very much, Andrew. Sore point, as we can't go to the hairdressers in Auckland, but just first world problems. Thank you very much. A great summary of life after diagnosis, really useful information there. So moving on to our next speaker, Dr. Jonathan Bishop. He is a paediatric gastroenterologist and hepatologist, at the Starship Children's Health, and his professional and research interests include celiac disease, inflammatory bowel disease, and cystic fibrosis liver disease. And Jonathan's going to talk to us about diagnosis of celiac disease in children. Thank you, Jonathan.
Thank you, Claire. I'll just try and wrangle with the technology. I'm notoriously known as a bit of a Luddite by my colleagues at work, so fingers crossed. Okay, so
Luddite.
I made it. I hope you can all see that. As Claire said, I'm going to talk a little bit about diagnosing celiac disease in childhood. Now, when I was at university, which is still just about within living memory, we were taught that celiac disease occurred in somewhere between 1 in 5,000 and 1 in 350, specifically in the west coast of Ireland, and presented often in the first 2 years of life with profound malnutrition, abdominal distension, diarrhea, weight loss, irritability and lethargy, and occasional so-called celiac crisis, where children became very suddenly unwell. And this really has shifted markedly over the last couple of generations, so that the presentation of celiac disease in childhood is recognized to be much broader, often occurs or is recognized later on, and generally occurs with much milder or more non-specific symptoms. In conjunction with that, it's recognized that actually screening of at-risk groups is important, so we not infrequently diagnose patients who don't have any symptoms at all or any recognized symptoms, but are simply tested because they're known to be at increased risk because of another condition or a family history. There are also patients who present with very atypical symptoms. So you'll all have heard the term dermatitis herpetiformis, which describes this intensely itchy, kind of blistering rash, often occurring in crops over the knees or the buttocks or the elbows. Some children present with dental problems, specifically underdevelopment or loss of the dental enamel. And as Kristen's already mentioned, bone health is particularly important in long-term untreated or unrecognized celiac disease. Into the adult spectrum, then the range of presentations potentially becomes even broader, with problems with fertility, psychiatric issues, neurological issues, the list goes on. Specifically, in our patients more locally, we looked at how they presented in 2 cohorts over around about 20 years separated from one another. And even in this relatively small cohort, it would appear that the number presenting with very obvious gastrointestinal symptoms such as weight loss, vomiting and diarrhea has reduced over a number of years. And those presented with more non-specific tummy aches and iron deficiency anemia and more generalized symptoms seem to have increased. Now, you've probably heard the term the celiac iceberg, and that refers to the fact that a small proportion of patients are recognized to have overt symptoms, and then under the waterline, there's a probably larger contingent of patients who either have no symptoms or whose symptoms are fairly non-specific or mild and aren't recognized. And then below that, again, there are patients who may be at risk of developing celiac disease. And certainly historically, the ones that we diagnosed were really the very, very tip of the visible iceberg, those that had really profound gastrointestinal symptoms. With increasing awareness of the disease and the range of manifestations and increasing accuracy of diagnostic tests, we hope that we've picked up a greater proportion of those who are symptomatic. But I think it's still important to recognize that there is a substantial majority of patients of people out there who may have celiac disease that are unaware of it and have not been diagnosed. So how do we make the diagnosis? Well, we get referrals from clinicians in general practice who've done the appropriate, what we call antibody tests, the blood tests, and then they're referred to us for further investigation. And in the past, what we did was an endoscopy where we looked at the lining of the bowel, and on the left, you can see a nice healthy lining of the bowel. And on the right, you can see the small intestine of the person with celiac disease looks a bit coarse, a little bit scalloped. And that gives us a clue, but really the diagnosis, at least in the past, was clinched by taking a biopsy, meaning a very small pinch from the lining of the small intestine, look at it under the microscope. And on the left, you can see multiple slender finger-like projections, which we call villi, on the lining of the bowel, and beneath that, little round glands called crypts. And on the right, all of those slender finger-like projections are blunted and lost, and the crypts, the glands, are enlarged, and there's an increased number of little inflammatory cells, which are the little purple dots in the top of the at the top of the villi. That approach to diagnosis has been challenged somewhat in the last decade in paediatrics. So in 2012, the European Society for Paediatric Gastroenterology, etc., came out with some guidelines, which they subsequently revised in 2020, looking into celiac disease in childhood. And this is quite an eminent organization. In fact, they evolved out of the European Celiac Society, and they recommended that for children with very strongly positive blood tests, that proceeding to upper GI endoscopy and taking a biopsy was not necessarily required to make the diagnosis. And we've looked at that in our population in the Auckland area and have shown that it holds up well in the paediatric population in Auckland as well. So what the criteria would be is that for children with the celiac antibody test, the most common one being the TTG, being very, very high, meaning 10 times the upper limit of normal, with the secondary blood test, the endomysial antibody, also being positive on 2 separate blood samples, just to make sure that we've not made a funny lab error or inadvertently tested the wrong person's blood. If those are positive, then we ask for referral to paediatric gastroenterology and we discuss the appropriateness of a biopsy-free diagnosis. I would make the caveat that it's important for the local teams to be absolutely confident and certain that the local labs are using the best blood tests and are quantifying them to the appropriate amount. So we've looked at this practice in Starship, and since introducing biopsy-free diagnosis into our patient group, more than 60% of children with celiac disease have been diagnosed without a biopsy, which we feel is good for children in that it avoids putting them through a general anaesthetic and an invasive procedure. It leads to a faster diagnosis, and from our side of things, it's led to a significant reduction in our wait list for endoscopy and our requirement for clinic visits, and from a health service aspect, significant cost savings. So in summary, we know that celiac disease is increasingly commonly diagnosed and actually seems to be becoming increasingly common overall, but that it remains underdiagnosed in the population, often because symptoms are mild, non-specific and not recognized. So having a high index of suspicion, speaking to appropriate healthcare practitioners and raising concerns is important prior to a proper diagnostic workup. And that certainly for children, diagnosis may be possible for a group without the need for endoscopy and biopsy.
Thank you very much, Jonathan. Thank you. Very really interesting. And in the interest of time, hopefully I see lots of people are putting questions in the chat, which is fantastic. So any questions for Jonathan after that presentation, just put them all in the chat and we'll try and kind of pull them together as themes so that we can discuss them with our experts and the panelists as well. So following on for Jonathan, we now have Anna Richards. Anna Richards is probably very well known to most of you probably. She's one of New Zealand's most eminent dietitians and has a real expertise and worked in the area of food allergy and intolerances for many years, and has contributed much to the nutrition and dietetic celiac space in New Zealand, but also globally. So welcome, Anna. And Anna's going to talk to us today about the standards of care for dietitians and best practice.
Actually, Claire, we have a slightly different topic for this group, but thank you very much.
Oh, no, sorry. Yes, absolutely. Sorry. Yeah.
Kind introduction. I'm obviously just not, here we are, we might actually make this work this time. What is happening?
Do you want Sarah to show your?
Yes, Sarah, if you could, that'd be great. I'm obviously completely inept.
Thank you. Messages from your dietitian.
Absolutely, messages from your dietitian. And I must add to your kind introduction, Claire, too, that I also have a celiac daughter, so live it as well as working it. So in considering what I was going to speak to you about this morning, I decided that there are some messages that you just can't hear too often. So we're going to whiz over some of those messages and the things that I see in my clinic on an every week basis. Message number one is celiac is a word. And I can't reiterate enough the importance of not only adults, but teaching children from as early as we can that when they're diagnosed as celiac, that they use the word celiac, especially with the proliferation of people following a gluten-free diet. So if you go to a restaurant and you ask for gluten-free, you'll get something that is gluten-free by ingredient, but it isn't necessarily going to be free of all cross-contamination. So just remember, anyone can be gluten-free, but only celiac can be celiac. Message number two is the annual celiac serology and the consideration that just because you believe that you're following a gluten-free diet, just because you look fine on the outside, it doesn't mean that you are on the inside. And I've seen through the chat forum that obviously this is still a struggle with people to get their GP to actually go along with this. And certainly I have heard of patients having a real battle, but I always suggest to new patients that you choose a date, whether it's your birthday, whether it's the date of diagnosis, and that you have your serology done on an annual basis. I was involved in a study a couple of years ago looking at people who had celiac disease for at least 10 years. And there was a full spectrum in terms of celiac serology. There were those that returned completely negative serology, but there were those who looked fine on the outside, but had serology akin to being completely undiagnosed. So an annual checkup, pop it on your list, choose a date, make it the same date every year and make it happen. Folate is a big one if you're contemplating pregnancy. Folate is one of our B vitamins. It's very important as far as neural tube development is concerned. And so having adequate folate in your diet ahead of pregnancy is really important. We do have a bit of a battle with folate and those with celiac disease. And I was having a discussion with my good friend Megan Ogilvie, who is at Fertility Associates, as to what their current recommendation is for those with celiac disease and folate ahead of pregnancy. They're currently recommending 5 milligrams of folate for at least 12 weeks ahead of conception. However, all our funded folate in New Zealand is actually gluten containing because they use the excipient they use is derived from wheat. And the over-the-counter folate supplements are actually very low. Often the highest over-the-counter that I could find is 800 micrograms. So it's going to get pretty expensive. So it's on my radar, and I've actually suggested to Megan that maybe Fertility Associates get this behind this as well in support of those with celiac disease having adequate folate. The issue is that folate, as well as being in our dark green leafy vegetables, is in a lot of our grains, which many of those with celiac disease have to obviously exclude from their diet. So be aware of it, just have a discussion with your GP and be aware that the current recommendation from Fertility Associates is 5 milligrams of folate a day for 12 weeks prior to pregnancy. Calcium, a big one in children in particular. Often what I see in patients who turn up in clinic is that they have self-excluded milk, because often we see a secondary lactose intolerance. It means that because of the damage to the villi, that we're not producing enough lactase, the enzyme that we need to break down the lactose so that we can absorb it and metabolize it properly. And consequently, after drinking milk and consuming things like ice cream and yogurt, symptoms can be that the patient or the child feels a bit bloated, feels a bit nauseated, might get a little bit of diarrhea, flatulence. And so often dairy products have been self-excluded from their diet, and that they're not replacing them with other adequate sources of calcium. The key thing to remember is that there are an increasing number of lactose-free products on the market, lactose-free milk in both fresh milk and in long life options. There's lactose-free yogurts on the market. Hard cheese is actually really low in lactose. And so actually making sure that we are addressing the calcium needs is particularly important. And as Andrew mentioned earlier, the risk of osteoporosis in adults diagnosed with celiac disease is relatively high too. One of the key issues is that when many people stop drinking cow's milk, they're replacing it with plant-based milks. And plant-based milks are very low in a well-absorbed form of calcium. So making sure that you've kept in touch with your dietitian and that your dietitian has adequately calculated the calcium that you need. And often with children too, that I would suggest if they've been diagnosed in, particularly over the formative years for teeth, that they see a paediatric dentist, because often the school dental system doesn't actually see the children often enough. Children can slip through the net. And so many of these children that I'm seeing have had significant dental issues, often broken bones as well. So making sure that adequate calcium is in the diet is really important. Fibre. As once again Andrew alluded to before, fibre can be a real issue in a gluten-free diet, and that many of the gluten-free breads and pasta products are actually very low in fibre. Fortunately, we're seeing quite an increase in products such as our pulse-based pastas, which are a really good option, rather than the old rice-based products. That was certainly the issue a few years ago. It's really important to include a wide variety of grains in the diet: millet, quinoa, amaranth, so that although we can't have our wheat, rye, barley, oat, triticale, that we replace them with alternative grains, that we're including pulses as far as we can tolerate them, and being really mindful that the wider the range of fibre we have in our diet, the greater diversity of your gut microbiome. So they're very important prebiotics. Often I'm asked by patients, how do I make sure that I'm having a really sound, nutritionally sound diet? The very, very simple message is the wider the range of foods you eat, the better the chance of having a nutritionally adequate diet. So many people I see with celiac disease stick to a very narrow regime. Keep life fun. I think it's really important to eat out, to trust others. Swap jar here is one of my favourites, that children don't have to say no when they're at a party. They can come home and just swap things for nutritionally safe and gluten-free options. I'm going to have to hurry. I've been given the quickie from time, but just the fish hooks from school daycares with Play-Doh and paper mache and cereal box creations. So just making sure that you've had a chat with your child's daycare as well. The best gift that you can give your celiac child is the gift of cooking. Teach them to cook so that they can be self-sufficient in their adult life. And every label, every time. And just some bouquets, particularly to Meg Thorson and Adele Rustami for their work on the dietitian standards of care. This was presented at the medical session earlier this morning and has been rolled out as a practice guideline for all dietitians throughout New Zealand to use in helping you, their patients, manage your celiac disease the best way they can. Thank you.
Thank you, Anna. Some really helpful tips and messaging from dietitians for some areas that we sometimes don't often think about when we think about the management of celiac disease. So really helpful. Thank you, particularly around the folic acid stuff. So moving on, in the interest of time, I'm going to introduce to you Bob Anderson. So Bob Anderson is our international guest, which is fantastic, but he did graduate in medicine from the University of Otago before he crossed the ditch. He is very well known for his research in celiac disease, but particularly for advancing our understanding of the molecular basis for immune recognition of gluten in celiac disease, and then subsequent research into the vaccine development or antigen-specific immunotherapy for celiac disease. So really warm welcome to you, Bob, and you're going to be talking to us today about symptoms caused by gluten.
Thank you, Claire. I'll just flick onto my slides. Yeah, so I came at this question during my time in Boston over the last 8 years as a drug developer, and the question that became very important in developing a drug was how could you show that the drug was influencing symptoms that people had with celiac disease if they ate gluten. And we found it very difficult to understand really what did gluten do when people consumed it. And there were many reports from patients who had celiac disease that they became quite sick when they had eaten gluten. But when you look in the literature, there was almost nothing about this. There were a few retrospective studies asking people what happened when they ate gluten, but there were very few reports of what you would call high quality studies where gluten was deliberately fed and then people were watched and asked and they were rating the severity of their symptoms. And this was actually really important because the FDA in the United States requires what's called patient-reported outcomes when they evaluate a drug. And if this patient-reported outcome tool has not been validated by asking patients what their experiences are, then the drug isn't usually approved. So this is a really important issue for drug developers, for doctors, dietitians, and obviously people affected by celiac disease. So what we were working on was really whether eating gluten reactivated gluten immunity in people with celiac disease, and whether that led to an immune activation in parallel with symptoms, and whether that immune activation was really correlated or driving the symptoms. So we recently published a study that arose from the drug development we were doing with NextVax2. And this includes quite a lot of data from people in New Zealand who'd volunteered for this trial. So we were evaluating what happened in the 6 hours after people ate gluten. The subtlety here was that instead of feeding people bread, which is what had been done, and then asking what happened, we were very conscious of what else was in gluten when people ate bread, for example. So we spent quite a lot of time trying to find a version of gluten that was very low in what we call Fodmaps. And the reason for that is that we know that Fodmaps are sugars which are poorly digested in the gut and they can cause irritable bowel. So when you swallow a slice of bread, you're being exposed to both Fodmap and gluten. With vital gluten, which you can buy from the supermarket, it's low in Fodmaps, and you therefore are getting the effect of the gluten in a much more concentrated form. So we fed people 10 grams of vital wheat gluten flour, which contained about between 6 and 8 grams of gluten. It's about half what you would eat in one day on an unrestricted diet, that we administered in a drink, in a kind of slurry that you would swallow over a couple of minutes in 100 mils of water. So it was a little bit contrived, but it was a way of efficiently delivering gluten and then watching what happened. So we collected blood samples every 2 hours for 6 hours, and people rated their symptoms every hour. We did this, people knowing what they were drinking, so we call that an unmasked gluten challenge. But we also had a version where we had a sham challenge as well, and they had 2 challenges. One is sham without gluten, and one the gluten version. I'm showing you the unmasked version, but the results were very similar between the 2. This shows you the severity of symptoms people experienced and when in the 6 hours after consuming the gluten. So if you look over on the left in the black and white panels, people rated their overall severity of symptoms on a 0 to 10 scale. And you'll see there in the first panel A, that very large group, 295 people, all had exactly the same challenge. And these were people from the US, from Australia and New Zealand. The peak severity of symptoms was at 3 hours. The onset of symptoms was by 1 hour. If you break it down by which symptoms were rated the worst, in panel B, you'll see that the red line is the highest. Red is nausea. If you look by contrast at diarrhea, which is the olive-coloured line, it's actually overlaid by the yellow dots here. But diarrhea was really rated pretty low by most people. And in fact, the only group who had severe diarrhea were the group with very severe symptoms overall. So if we focus here on the 2 extremes in this group, there were 8 people out of 295 who said they had no symptoms at all. So they were flatline, nothing happened. If on the other hand, it was the group with very severe symptoms, these were people whose symptoms were really quite pronounced even by 1 hour, and by 2 hours, they were really quite unwell. But you break it down by what symptom was worse, again, it's nausea. And nausea was really very pronounced and accompanied in this group, usually by vomiting as well. The symptoms overall, though, were improving by 5 hours, and people were, distinctly recovering by the time it was 6 hours. So this is the gluten reaction, and surprisingly, this had not been done before. And this paper was published just a year ago. So this is new knowledge, and it really shows how unwell people can become when they have a gluten exposure. We were interested to know, though, what was going on, which was driving these symptoms. And in this paper we published last year, we were demonstrating what were the immune markers that were going up and changing during that reaction. And here you can see, according to the severity of the overall symptoms, the people who had severe reactions in red were driving up high levels of these immune markers in blood. And again, this had not been discovered before. Interleukin-2 is derived from T cells. So these are, we know there are gluten-reactive T cells. And it appears that interleukin-2 elevations are showing that those T cells are being activated very quickly. And there are a variety of other markers that derive from the immune activation phenomenon that are also going up. Some go up very quickly and early, like interleukin-2, while others are delayed. And so this one here, IL-10, is coming up later on. And it probably reflects a cascade of immune activation events going on. But remember, these are in blood, so the whole body is being exposed to these immune markers that can themselves drive inflammation throughout the body. The variety in reactions, though, here shown by the levels of interleukin-2 that go up in the blood is highly variable. So many people have really very mild reactions down here at the bottom end, but at the top end, these are very dramatic reactions. So these levels of interleukin-2 are only seen in people who are extremely unwell. And normally in studies, these are people who, may be in intensive care. These levels, though, don't last for very long, they're transient. The factors, though, that influence the severity of the reactions were very interesting. So we were able to show that in patients over here on the left, the patients who had worse gut histology in the duodenum were the ones on a gluten-free diet who were having more severe reactions. So a more healed gut meant that there was less reaction. If there was a damaged gut with villus atrophy on gluten-free diet, these people had more reactions. If someone had 2 gluten challenges 3 months apart, the reactions were very closely correlated. So severe reaction on the first occasion predicted severe reaction on the second occasion 3 months later. If you look at the genetics, the patients who had HLA DQ2.5, the classic HLA type, they had more severe reactions than the people who did not have that classic genetic background. In the second box here, the people who had a double dose of the DQ2, again, they had more severe reactions than the people who had a single dose of the DQ2 gene. In this companion paper, we were also addressing this question of what factors were really underlying the severity of reactions. And in this finding, we were able to show that the number of T cells, so lymphocytes in the blood circulating in a patient reacting to gluten, predicted the severity of the gluten reaction. And then on the right, again, we showed that the damage in the gut, if it was more severe, it predicted a more severe reaction when someone ate gluten. So summarizing, gluten reactions and symptoms can occur very quickly. Some people, it's a very severe reaction. It's really like food poisoning. It's not what people expected by and large. Many people were expecting diarrhea. They didn't get diarrhea. They got nausea and sometimes vomiting. So what influences the symptoms appears to be the dose of the gluten, the matrix, and by that I mean whether it was in a liquid form or in a solid form, what else was in the gluten food. So the particular thing here is Fodmaps, and in wheat flour, there's high levels of fructan, and in some people this can drive irritable bowel. And equally, it means that irritable bowel symptoms can occur without gluten in celiac patients. Whether or not people have been previously exposed to gluten over the recent few days can influence the severity of reaction. We know in many untreated patients, they actually have no symptoms. So the status of gluten immunity is really critical, genetics, and ultimately, it's likely to be the status of the gluten immune response and how many T cells there are waiting to respond to gluten. And on that, I will stop.
Thank you very much. Thank you very much, Bob. A lot of very useful information distilled into a short presentation. Thank you. In the interest of time, because we are kind of running out of time, and I know I've been checking the chat and there's a lot of some really interesting questions. I see Andrew has responded to a few of those. We've also got our other panelists, so I'll quickly introduce those people to you who will also assist with some of the Q&A. So we have with us today Dr. Cameron Rustami, who's a consultant physician and gastroenterologist from Palmerston North, so quick wave from you. Hello. We have Dr. Simon Chin, who is a paediatric gastroenterologist from Starship Children's Health. And then we also, hello. Hi Simon, hello. And we also have Sylvia North joining us, who's a very experienced dietitian and integrative nutritionist in Auckland. And also we're joined by Meg Thornton, who again is a highly experienced dietitian in this area, and particularly with food service systems. And she was instrumental in implementing the dining out program for Celiac New Zealand. So Andrew, have you got a kind of feel for some of the themes of the questions? I certainly picked up after Kristen's talk that people really want to know, should they be going to their clinician or GP, the healthcare provider, and demanding for regular, yearly checkups for not only in terms of their celiac disease, but for, other biomarkers that you mentioned in your talk. Should they be insisting on that? There were a few questions about that I saw in the chat.
Well, first of all, to be fair, and I was sort of alluding at it, there's not sort of a national agreed follow-up plan. In the South Island DHBs with the health pathways, they do include what is suggested to be follow-up, and that does include ongoing GP review and bloods to follow, as well as looking at weight and adherence and symptoms and so on. But having a national approach to that would certainly be good, and yeah, so not all centres will do things the same way.
Andrew, did you notice any other themes in the chat as well that you thought?
There were some questions that Bob might be best to answer that was specifically for him more recently, in the more recent chats.
Oh, okay. So things about diarrhea. Does that indicate a Fodmap issue? Do you think it's worth taking charcoal tablets to help get rid of the gluten reaction? So there are a few things in there. Yep.
So I was surprised that diarrhea wasn't more important. And in the previous work that had been done by people recalling gluten reactions, diarrhea had come out as a very important symptom. But no one had actually done, in my mind, the right experiment, which was to deliberately feed gluten. And so the diarrhea that people experience and report as being a gluten reaction, you'd be tempted to say it's probably not gluten if it's diarrhea without nausea. So the presence of nausea came out as such a significant symptom, and that's been replicated. It seems that the diarrhea by itself is probably more irritable bowel. And we know that irritable bowel is more common in people with celiac disease on a gluten-free diet. But I would guess that FODMAP-related diarrhea is probably more common than we give it credit for. And therefore, in terms of educating people, and this is really a comment and question for the dietitians here, in terms of educating people about a gluten-free diet, it may be that you should also be educating in parallel the importance of FODMAP avoidance in people who have irritable bowel before or during their gluten-free diet. And I think the other thing is that if you only have a dietitian education session at diagnosis, that's fine, but symptoms change as people remain on a gluten-free diet for longer. And that severity of gluten reactions become worse. So I was able to show a few years ago that once you've been on a gluten-free diet for 2 weeks, many of the symptoms begin to lift, but you also become a lot more sensitive to gluten exposure. And I think the irritable bowel probably reflects underlying inflammation in the gut.
There is also that issue of sort of the microcontamination, and there is a question for the dietitians here about should celiacs avoid products made in the same facility as wheat-containing products if they don't experience symptoms after consuming. That's a great question. Meg or Anna or Sylvia? Anna, you're on mute.
Because precautionary labelling is so loose, because there is no one standard that manufacturers adhere to in terms of whether something contains gluten or something doesn't, it's a very difficult call to make. I generally don't exclude foods made on a line, made in the same facility. But I ask patients to put their sensible hat on. If they look along these supermarket shelves, and 9 out of 10 products that manufacturer are making are actually gluten containing. Eating 1 out of 10 doesn't is probably a higher risk. But unless they continue to have continue to have ongoing symptoms, that their serology isn't coming back into line, then I typically turn a bit of a blind eye to that. The problem is at the moment that labelling legislation for allergens and for gluten is under the same legislation, and they don't need to be, and that will change over time. just to your comment before, Bob, about Fodmaps and celiac disease, I would tend to leave that conversation till a later conversation, because I think it's really important in that initial assessment that there's a thorough understanding of celiac disease. But that is something that I will address in further consultations. I do agree with you, though, that if patients are only seeing a dietitian at diagnosis, then there are a lot of conversations that aren't being had further down the track. Now, I will typically catch up with patients, ideally 4 to 6 weeks after their initial diagnosis, but I'm in a fortunate situation of seeing patients in a private facility.
And that just leads on, in the interest of time, I'm afraid this is going to have to be our last question. And I'm just wondering, we've got a lot of great questions in the chat, and I'm wondering if we could maybe capture those and have some maybe follow-up Q&As on the website, Wendy, after the conference. Not sure, but just an idea. Just really in response to your your talk, Anna, about the importance of, you brought up about calculating calcium in someone's diet to ensure they're getting, you can advise them on adequate amounts. I'm just wondering, is that, somebody asked, is that the norm? People, would that be the normal practice that you'd expect after diagnosis to see, a dietitian, and they would then calculate your nutrient requirements and advise you accordingly?
Absolutely, absolutely. That will be part of the initial dietetic consultation as to what your likely intake is of your key nutrients and what we need to do to either make that up, ideally through the diet or with supplements if we need to.
And would that be ongoing? Particularly, I'm thinking in the paediatric and in children, would that be an ongoing thing that you'd recommend as well?
That would just be a running standard in the care of that patient.
I wanted to add to that, because nowadays we have tools that nearly everyone can access, and the app, you can download Easy Diet Diary, which is on Android and iPhone, and so that's a tracking app where you can do your own food diary, and it does have calcium information and iron and fiber, so that is actually based on a validated local database, and uses the same technology that a dietitian would evaluate for you, so you can do that just to get to know your own diet, which I think is a really good skill.
Great, thank you. Kristen, you're going to have the last say.
Sorry, I just wanted to make a quick comment about Anna's comment about requesting an annual serology test from your GP. Just a word in defence of GPs. It's not always solely up to the GP as to whether or not they can do that blood test. Some of the laboratories have particular protocols in place in terms of when they will and won't process blood tests that in a subsidised way. So, I mean, this is a conversation that I think we need to have along with guidelines around annual reviews of people with celiac disease, and going to your GP and insisting on a blood test. It's not always going to produce the outcome that you would like, because there's a whole lot of evidence stuff and financial stuff and politics in behind all of that, not all of which sits, the responsibility of which sits with GPs. So in principle, it's a good idea to be thinking about to be monitoring celiac antibodies, but we're not there yet in terms of being able to say it's a definite, you can rock up and ask your GP for that and expect to be given a yes to that. So just to urge a little bit of kind of tolerance and sort of not necessarily getting grumpy with GP if that can't happen.
Thank you, Kristen. Now I'm going to go around and ask everyone one quick key message. That can be your key message, Kristen, from your talk. One key message for people to take away from your talk presentation. Andrew.
I guess just the key thing that this isn't just about the diagnosis. It's not about just starting on a gluten-free diet. It's a journey beyond that, and there's lots of different parts to that journey.
Thank you. Jonathan.
I guess the kind of start of the diagnostic journey requires a degree of awareness and understanding of celiac disease as an entity, which is very much partly a medical issue, but it's also important to get out there into the wider world about how celiac can present, particularly in childhood, in such a variety of ways.
Thank you. Anna.
It's really important to follow a completely gluten-free diet, but don't forget to live. No, don't be so scared that you only prepare your own food. Get out there and eat out and trust others to cook for you and still enjoy your food life.
Thank you. Bob?
Well, gluten reactions can occur without symptoms, but they can occur with dramatic symptoms like food poisoning. And the symptom that's most sensitive for a gluten reaction is nausea. And that's the one you should be talking to your dietitian and GP and gastroenterologist about.
Thank you. So thank you to all our presenters for their fantastic presentations, and particularly with the time constraints. I think you all did an amazing job. Thank you to our panelists also for joining, and thank you participants for really engaging and participating in this session. Fantastic questions, and we'll hope to maybe get to some of those and collate them, maybe some more Q&As on the website following the conference. So I hope you all have a fantastic rest of the day at the conference, and yeah, take care.
Thanks again, Claire. That was an awesome session, and it's a shame we didn't have all day to listen to the medical advisory panel, but the questions will be saved specifically so they can be passed on after the conference. So if the MAP wanted to go in and answer any in the meantime, but also we can share with you later. So thanks everybody for your contribution. That was great.
Yeah, that was fantastic. It's always one of the most popular parts of any conference, I think, and if we could do an entire conference dedicated to this, I think it would still be a great success. So thank you all again for helping out and enlightening us. Cool. Okay, so I'd just like to thank our third platinum supporter again, Lavender Cottage. I'd like to invite you to go onto the supporters page and enter the competitions again, and you can book a time to meet Ruth Gilling, who is the owner, and discuss your celiac safe catering needs, and also find out about the Christmas meal boxes. So I'd like Sarah to please load the presentation from Lavender Cottage.
Hi, I'm Ruth, the owner of Lavender Cottage. I'm going to take you on a tour of our new shop. So here we have our brand new store with our lovely assistant Olivia at the counter. And here is our deli. And we have all sorts of gorgeous food, chocolate mousse that flies out the door, lemon meringue pies, a vanilla loaf, we have a Louise slice, we have sourced some gluten-free lollies, we have gluten-free ham, we have some gluten-free deliciously yum salads, and then around here, this is very exciting, we have hot, ready to eat gluten-free pies in the pie warmer. They're replenished right throughout the day. We have a vegetarian pie, a mince pie, mince and cheese, steak, steak and cheese, steak and mushroom, bacon and egg. And they have been flying out the door. And then we have our Christmas cake, which a lot of you would have already sampled, and our Lavender Cottage cookies. And then we go around here, we've got a freezer full of deliciously yum pizzas, cupcakes, ready-made meals. I'll just give you a nice close-up of the ready-made meals. These are all packaged up. This is a roast chicken meal with gluten-free gravy in it. This is a vegetarian and dairy-free pasta bake. We have a range of other people's products. Here we have some Allergy-Wise products. You can get Allergy-Wise garlic bread from us. We have the buns, we have a range of the different loaves of bread, and we have some Turkish pies down the bottom there. Then we come down here and we have our own range of products. We have coconut chips and coconut flour, our own range of herbs that have all been processed on equipment that is completely gluten-free. We have a range of flours We have some cornflakes, and then we come around the corner. We have pasta sauces, pastas, some alternative bread that we're stocking, and our own mixed fruit. We have some Fudge and James biscotti and cookies. We have some Fog Dog products, and getting more products in all the time. More gluten-free lollies, and our deliciously Christmas cakes, as you can see. Yeah, so that's us. That's Lavender Cottage, home of gluten-free. And out the back, I'm just giving you a quick snippet of our completely 100% gluten-free, celiac safe kitchen.